Loud and clear.
How about Lenore?
We've got you, Jesse.
I'm not gonna put the camera on myself because it may break it again. Okay, can everyone see the presentation?
No.
Oh, boy.
You want me to bring the chair over there, Jesse?
Now, can everyone see the presentation? I'll get
Yes.
you straight.
You just got the loud, Jesse.
Oh,
Sorry,
can everyone hear me?
Yes.
Raise your hands.
Can you hear us in Silva? All right, can you hear us in, you can hear us in Lenore,
Everybody raise their hands.
and everyone in Asheville can hear us too. And we're back in our sweatshop. Okay. I don't even know what we were talking about in the other room. But what we're going to do is try to get through this presentation so that I can give you a little bit of an idea about what is in the waiver amendment. So what we'll be looking at today is really just touching on why resource allocation, why the state wants to move that way, how resource allocation works. We'll touch some on the supports intensity scale, individual budgets, plan development review, and then we'll talk some about the services that are in the technical amendment. There's some new services and there's some changes to existing services. The reason that the state needs or is moving towards resource allocation is because there's a continuing increase in service demand, and the resources available to pay for services are stagnant. In fact, if you look at the budget that was recently passed, they're almost declining in some ways. So we've got to have a better way of distributing the resources that we have. And in North Carolina, it's estimated by this website that looks at waivers in every state. It's estimated that the average length of wait for a waiver slot is 7 to 10 years. So if that's average length of wait, that means there's people waiting well past 10 years.
Yep.
And just in our catchment area alone, we have over 1,000 people that are potentially eligible and are waiting for innovations. And statewide, the number's probably close to about 13,000. About the same number of people are waiting for the waiver as are receiving the waiver statewide. So that's why we've got to be better with our existing resources. And the whole idea behind resource allocation is to move the system away from one that looks scattershot, like the graph in the upper left, to where the services that people are receiving aren't really tied to the services or aren't really tied to their needs. It just is just a random array of some people getting a lot, some people getting a little, and it's not really matched up well to what people actually need. And we want to move the system into something that matches needs to resource funding. And that's noted on the bottom right of this slide. If a person has small needs, they should be getting small amounts of service, and vice versa. And here at Smoky, we're committed to ensuring that people with intellectual disabilities are as integrated as possible in the community. And we actually see resource allocation as a way to accomplish this. And we're wanting a system that is fair for everyone, based on needs and choices, so that people get the services that they need when they need them. And people with disabilities have the opportunity to live in, to exercise the rights of citizenship and live in the community as independently as possible. And to get there, we're going to have to build on our successes. I mean, this system has done some pretty incredible things in the chaos that has existed since reform started. Since 2002, there have been numerous shifts in this system, but it's been rather resilient. And, in most circumstances, people are still getting the services they need, but we've got to do a better job of ensuring that that occurs. And we've got to make sure that we're spending the money that we have as efficiently as possible. And the whole idea behind resource allocation and how it works is that it's a 5-step process. People will have a CIS. That CIS score will result in them being assigned to a category, a budget category. They'll be assigned a budget. They'll plan for services, and those services will then be provided. And now I'm going to break down each of those steps. The CIS, every adult in the state has received a CIS. Every adult in our catchment area that's receiving waiver services has received a supports intensity scale. And right now, the American Association for Individuals with Intellectual and Developmental Disabilities is administering CIS assessments to children. And by the implementation of this technical amendment, all children in the state should have an assessment completed before resource allocation starts. And other states that have implemented resource allocation have not used such a large sample. North Carolina did a very large sample in developing their resource allocation model. The CIS is completed, and then a category is assigned to the person based on the needs identified in the CIS. Now, the CIS, as I said, was developed by AAIDD. It's recognized as a reliable measure for services. It's strength-based. People participate in CIS interviews that know the individual well, and the whole assessment starts from the place of assuming that people can do things, and then determining how much support they need to accomplish those things, which is a different way of looking at people with disabilities if you think about the way we've always done it. We usually take a look at a person with psychological assessments, IQ scores and adaptive assessments, starting with what they can't do. The idea behind the CIS is to start with what people can do, and then how many supports do they have to do more. The CIS has 3 sections. First is the support needs about home living, community living, their lifelong learning goals, health and safety. Section 2 talks about the participants' needs to advocate for themselves and manage their own money and make choices. And then Section 3 touches on medical and behavioral challenges that people with intellectual disabilities may have. And in each of these sections, really basically 3 types of questions are asked. What type of supports does the person need? And, do they need verbal prompts? Do they need physical assistance? The type of support they need. How often they need that support? Do they need it on the hour? Do they need it every few hours? How many times a day? And then how much support that the participant needs. And then in North Carolina, we use some supplemental questions to identify what people that may be considered outliers. And the supplemental questions touch on severe medical risk, severe community safety risk, a person that has been convicted, severe community safety risk, not convicted, and then severe risk of injury to self. We pay attention to these issues because the CIS doesn't necessarily touch on this until you get into the supplemental questions. After the CIS is completed, each person gets a score, an index score, so to speak, and the support needs identified in that score results in the person being assigned to a budget category. Well, these budget categories were not just randomly created. And unfortunately, I don't have the details around the budget categories yet because DNA hasn't provided them. The process that's occurred to create these budget categories has been a long one. North Carolina started administering supports intensity scales to persons in 2004. There was a pilot that ran from 2007 to about 2010 that Smokey was a part of. Those test scores were not really used because of the way the system has evolved. But there's been a lot of engagement by the Department of Health and Human Services in North Carolina with stakeholders. There's been meetings about twice a month touching on the supports intensity scale. There's been consistent education provided about the supports intensity scale and ideas around resource allocation. Resource allocation has been used in the original Piedmont catchment area or the Cardinal Innovations catchment area since 2008, so about 6 years. And there's also been the assessment of every individual in the state. So everyone that is on the waiver and receiving services that's an adult has already received a supports intensity scale. And with that information from stakeholders and the assessments, Burns and Associates and Human Services HSRI, Human Resources Services Incorporated, HRSI, developed categories, and these are descriptions of people that have certain CIS scores. And they had a group of 25 people get together at the end of July in Raleigh, which was, the temperatures were more pleasant than they are in this room. And during that validation process, that group looked at 100 charts. 100 charts for adults and 50 charts for children. And compared, they basically fit people into the category descriptions. And those category descriptions were then compared to where the person would have been placed by their CIS score. And there was a lot of consistency in the CIS score and the category that the person moved into. And that information was used to create the category descriptions that we should be getting very soon. The category descriptions were changed because of that, and we'll get into that a little bit later. But the category descriptions are created, people are assigned a budget, and that's where their plan meeting starts. And the budgets are determined by a person's CIS score, their living arrangement, and their age. And that equals a person's base budget. A participant that's assigned, they get their base budget that's given before the planning piece. It's not the way it has been where we start attaching services to a person and then put the money in behind with the cost summary. In this model, the treatment team or planning team is notified of the amount of money they have to spend for base budget services before they start planning. And then that planning team chooses the services that they feel best meet the person's needs, staying within that budget range. The participants meets with the care coordinator, they write the plan, it's signed, and then the plan's submitted to utilization management for a medical necessity review. Now, the base budget services identified in the technical amendment that's posted are community networking, community living and support, day supports, respite, and support employment. This is different than the posting that was placed for public comment. Public comment included residential supports and supervised and supported living. Those have been pulled out of the base budget services because of information that was gathered during that validation process. because it was too limiting for people that were in those types of settings. All of their money would have been going towards their residential placement if they were not pulled out of those services. So those people will have a different budget category going forward. And then your base, a person's individual budget is their base budget services and their non-base budget services. That makes their annual individual budget, and that annual individual budget cannot exceed the labor cost limit. Can anyone tell me what the labor cost limit is? 135,000, right.
But since you've increased ICF and Mars, is it going to go up?
No, not in the proposal. The number's still 135 for cost neutrality. And that's a different topic. But
Yesterday question.
the non-base budget services that are indicated in the waiver are assistive technology, community guide, and actually it's called community navigator in the posted amendment. Community transition services, crisis services, home modifications, individual directed goods and services, natural supports education, residential supports, supported living, specialized consultation, and vehicle adaptations. These are not considered base budget services, so on that previous slide, they would be the non-base budget services paired with the base budget services towards the annual budget. Now, knowing that information, the team meets and the participants informed of how the process works and what their base budget is. They're also notified that the base budget is a guideline. That base budget that's given to a treatment team is not a limit. And we've got to be really clear on that. It is a guideline. There's a range, and people can request beyond that or below that, depending on what they feel their needs are. If they go beyond that, it will be reviewed, and if denied, it would require, due process rights. But people cannot be told that the base budget is a limit, because it's not. It's just a guideline. And the care coordinators will make sure that folks understand that. The team develops the plan, and the care coordinator writes it down. And the care coordinator must request what the team deems is necessary in the planning process. That goes back to that base budget piece. If your base budget is $50,000 and you feel you need $60,000 worth of services, the care coordinator will request $60,000 worth of services. The plan is submitted by the care coordinator to utilization management, and the waiver is very clear that the MCO has a care coordination department that's separate from the utilization management department, just like Smokey's currently set up. And I'm repeating it again that they request what they want, whether it's within that budget or not. And utilization management reviews for medical necessity. Well, now, if utilization management reviews,
wait a minute.
And says, say you're requesting 60 and you just got 50. They can't deny it based on the budget limit, but they can deny based on medical necessity and offer you due process rights, similar to how it works now. And then after the plan's developed, the services are provided, and this care coordinator will work with the team to make sure that providers are available to the best of our ability. And then the plan belongs to the participant on the waiver. So the services, people's lives change. Sometimes people need additional things. Those requests come in the same update process, because there's processes for requesting add-ons to the budget. A person needs a vehicle modification midway through the plan. A team would meet and do an update. Now, that's how the resource allocation process works. Now, this waiver amendment breaks budget categories into 3 different living arrangements. If you remember, I said that the base budget is determined by your SIS score, where you live, and what else? Your age. So that's where you live is broken into 3 categories: provider-owned or leased homes. In situations like that, you're going to be using residential supports. These are AFLs, 6-bedroom homes, 3-bed AFLs, anything where the provider owns the home and the person's living there, or the provider owns or leases the home and the person's living there, it's residential supports. In circumstances where the person's family owns or leases the home, the service that will be used will be community living and supports. And in circumstances where the participant owns or leases the home, a new service will be used called supported living. Community living and supported living are both new services, which I'll talk about a little bit more. The limits on the sets of services in the waiver amendment do not change that much from the existing limits. Adults that are receiving residential supports or supported living, they're going to be limited to 40 hours per week of community networking, day supports, or supported employment accommodation. You'll notice that they can't receive community living and supports. Persons that live with their family, they're going to be limited to 84 hours per week of community living and supports. Community networking, day-to-day supports, and support employment and accommodation. There are processes outlined in the community living and support definition that allow the person to receive more than 12 hours of services for 90 to 180 day period.
Question,
I want you to say them to the end if you don't mind. Because we're pressed for time. I typically like to answer as I go, but since we got started an hour late. Children receiving residential supports are limited to 40 hours per week of community networking and day supports, or supported employment in combination when school's out of session. When school's in session, they're limited to 20 hours. And when they live at home, it's 84 and 54, and again, the exceptional needs pieces. So those are all limits that are familiar to us. This is a newer limit. Assistive technology equipment supplies and home modifications are limited to a combined 50,000 over the life of the waiver. So a person that needs a home modification that costs $30,000 can now access that home modification. It just comes out of their total $50,000 for assistive technology and other things. Now, this is life of the waiver. Since this is a waiver amendment, anything that has been spent in the last 3 years counts towards this $50,000 total. So a person that received a home modification last year for $25,000, they would just have access to $25,000 with this waiver amendment. The budget limits by level of support. That's the resource allocation. That's identified in the limits on sets of services in the same section of the waiver. That's not a hard limit. It's a guideline, as we've talked about already. I foresee that people that have all the pieces in place and are within their resource allocation budget, it will probably be much easier to get through the approval process. But they'll still do a review for medical necessity. You're still going to have all the pieces present. And then, of course, the annual cost limit will still exist for this waiver of $135. Now, one of the new services in the waivers, supported living, and this is a daily service for participants that live in their own home, or they could be renting a home with 2 other participants. They could be living in a home with one other participant and a live-in caregiver. There are several different ways that it could work out. It just has to be a lease arrangement where a lease or owning arrangement where the participant is the leaseholder or owns the place. This service is allowed by state law 2011-202, House Bill 509. That's the one that waives the licensure requirements of the person renting their own home. So, because there are people with intellectual disabilities that can rent their own home, and this law will actually, one of the guys that, one of the people that pushed this law through, Mike Mayer, he was a real vocal advocate for it. And I remember him asking me a question about it in 2010 about why do we have to license the residents if we're licensing the service, credentialing the service. Because he used that as part of the remark. He's actually dying of lung cancer now, but that's one of his legacy things is he actually pushed through this. And this law can be used to increase independence for persons with intellectual disabilities. The service, this supported living, I'm going to call it supervised living, but it's supported living, and it's going to be available in 3 different levels. And those levels are determined by clinical and supports assessments. I mean, it's not limited to the CS, but it will include the CS and person-centered planning. And there's ways to adjust each of the levels for short-term needs. Perhaps you have a person who's really a level 1 that can afford to live in the home if they have a roommate, but they don't have a roommate. So in order to make the residence work until the person finds a roommate, we pay a little bit higher rate. That's some of the flexibility that's available. So that's one of those special needs adjustments. The levels, one of them's minimal support. The person doesn't require staff to be in the home or awake at night. Moderate support. This is a situation where the person could be monitored overnight with technology, or it does not require someone to be awake either. Maybe on-site for technology. And then level 3 is someone that would require awake overnight staff. People that receive supported living cannot receive community networking, day supports, or supported employment, and they also can't receive community living supports because this is subject to the limits on sets of services. The new service, a blended service that includes habilitation and individual support. This service is going to replace in-home skill building, personal care, and in-home intensive supports. It's a blended service that takes place of all 3. The idea behind this is it eliminates the need to go to identify one activity as personal care, one activity as habilitation. It allows people to work with persons with a normal flow of life because training opportunities present themselves all the time. As do care scenarios sometimes. This is provided in the participant's home or family home. There's some language in the definition, and if you all recall, we talked about this almost 9 months ago, about providing technical assistance to unpaid supports. The staff can work with folks to help them understand better ways of working with the individual where it's applicable. And typically this service will be limited to 12 hours per day maximum. It is subject to the limits on sets of service, which means the most you can receive in a week's 84 hours, unless there's exceptional needs. And the exceptional needs criteria allow for a person to receive up to 16 hours per day for a 6-month time frame. And persons that need more than 16 hours per day may only be approved for up to 90-day periods. So as was mentioned with that last definition, in-home skill building, in-home intensive supports, and personal care will be gradually replaced with other services. Persons that are living in their own home will likely transition to supported living if they're living in their own leased home. We have a few folks in our waiver like that, maybe 5% of the population we serve. And then persons that are living in family homes, their periodic services will have to transition to community living and supports. Well, the waiver amendment, as it was posted for public comment, had this transition happening the day that the waiver went into effect. But feedback from stakeholders changed this. So now if a person has an authorization for in-home skill building and personal care, the day that the waiver goes into effect, those two authorizations are good until they expire. So we don't have to do massive rounds of updates, all on the same day around Christmas. Well, if you sell winter holiday, whatever we want to call it. But now the teams will be allowed to, if a team wants to meet and change the plan to where it shows community living and supports, they're allowed to do that as soon as the waiver's passed. Or they can stay, they can continue to use the in-home skill building and personal care or in-home intensive supports until those authorizations expire, at which point you'll have to do a request for community living and supports. And the individual budgets will be phased in kind of the same way. It's really like we'll be addressing plans and individual budgets as the person's annual plan comes up, unless something happens before that, which will be a lot easier than what we've done in the past. Those of you that were around in 2011, we transitioned people from CAP MRDD to CAP IDD to Innovations in the course of a month in the Western Highlands area. So it was a lot of confusion. That will really help, I think. Residential supports has been changed to allow respite and AFLs, but it may not be billed on the same day, which that's not exactly what they were talking about originally.
No kidding.
But the way it's been changed is if a person receives residential supports on Saturday, they can't receive any respite that day, but they could receive respite all day Sunday, just no residential supports. And I think the logic behind not allowing it to be billed on the same day is just a cost control, because in the CAP MRDD waiver, you would have people that would bill residential supports and 16 hours of respite on the same day. And fail safe, well, if you don't make respite available on the same day, it just that can't happen. Residential supports is not part of the base budget. The level of residential supports that a person receives is not influenced by the SNAP anymore. We're finally at that point where the SNAP will be disappearing from Innovations. Well, with the implementation of this waiver, I said from Innovations. Doesn't mean we will not still be required to use the SNAP for reporting purposes. We're really good at creating forms, but you talk about making them go away. That's a different act.
You'll still need to have a SNAP to get any type of services in ID.
It's supposed to be phased out over time. I'm hopeful it'll be pretty quick. Okay? It will not be considered in decisions about innovations because it has no place in that array once you're using the CIS, the plan. And then in this residential supports definition, instead of using SNAP index scores to determine a level for residential supports, the level is determined by category. And so that points out that we're looking at 7 categories. A, B, C, and D, E, F, and G. I already mentioned that respite may be provided in licensed or unlicensed AFLs, just not on the same day as residential supports. This is a pretty big change in the posted document as compared to the public comment document.
Wow.
Within 2 years, it's expected that direct support professionals demonstrate in some way competency in communication, person-centered practices, evaluation, observation, crisis prevention and intervention, professionalism and ethics, health and wellness, community inclusion and networking, cultural competency, education, training, self-development.
Oh, wow.
Now, that's a lot to add to the expectations that already exist. And I think everyone's aware that lots of things will have to change to meet this expectation. These competencies are directly from CMS, the Centers for Medicare and Medicaid Services. What we don't want is this competency list to become a checklist that people just check off and sign. We would really prefer some type of certification be attached to some of these competencies. But a lot more is to come with regard to that. Just know that this isn't a waiver. And we were in an integrated, a whole person care meeting, WPC meeting, earlier today, where these are the kind of things we're going to have to think about going forward, is making sure that staff are skilled at doing these things. Because direct support staff are the ones that help people fulfill their life more than any of us. And now, of course, the challenge is making sure they get reimbursed to where these things can occur. So that's in the waiver. Relative as direct service professional is addressed in the new waiver document. The only service that will be allowed in this process is community living and support. The document says that it's recommended that no more than 40 hours per week be provided. It takes away the approval process for up to 40 hours a week. So all that provider agencies will have to do going forward with the passage of this waiver is notify the LME MCO that they are employing a family member that lives in the same home. If it's up to 40 hours. Then all that's allowed after that's up to 56 hours per week in exceptional circumstances. Now that will require an approval process through the MCO. So we'll be revisiting our processes and setting up a notification procedure and then a way for providers to request up to 56. Now, it also allows in the waiver that participants that are currently receiving greater than 56 hours per week from a relative that lives in the same home, it allows for them to continue to provide that service if the participant continues to choose the relative as their direct support professional.
Good girl, you tell
If
him.
there's no health and safety concerns noted,
You tell him.
the participant's not isolated from the community, and then of course the MCO has to still review it.
You're funny.
In all circumstances where the relative is the direct support professional,
You're funny.
there's increased monitoring by the care coordinator to ensure that payment is only made for services rendered. And this is one of those things where there will be a requirement for time in, time out on data sheets and those kind of things, because it will be a little bit cleaner with just one service. There's not the back and forth about, I got to change from personal care to training. It's just you're providing service from this start time to this end time. So that's parts of those things. Oh, and now the slide that we all dread most. The question is, oh, and comments too, because things that were not, any way that this can be improved, please share it also.
It's gonna be available online.
Eventually.
What was the question?
Is it gonna be available online?
Oh.
It's tiny print.
Oh, wait, it's printing. Yeah, it's not that bad online.
No, it's not. That's what I asked, because if I'm gonna share it with my staff or my board, it'll help me to have it where I can read it.
So the forums instead of doing the three slides,
YouTube. Okay.
The rule of seven, and you do it PowerPoints, and you know, you've got an awful lot of information.
Well, you know how government PowerPoints are.
Yeah, but they're usually red, white, and blue. Yes.
Okay, so less information on each slide.
Or just so that it's readable.
One more slides.
one specific slide, the one that says supported limits on sets of services. When I was first listening, I was thinking they were connected, and they're three separate limits.
Okay. So that kind of define the categories.
Well, like when you said the 50,000 on thing, the 50,000 on your equipment, I thought, wait a minute, if you have, I mean, the bond said 135. So I was taking 150 off of 135, and then I realized these were three separate things.
Okay.
See what I'm saying? You know, don't have it so you know how to do it, but there are three separate.
So probably break it out into separate slides.
Yeah. So you'll try to do that. Okay.
So Jesse, with the various living arrangements,
Mm-hmm.
the first one is provider owned or leased. If you look at our one-person AFLs and maybe some of even the three-person AFLs, the family, not the client's family, but the AFL family owns or leases that, not the provider. So it would still be residential support, I think,
Yes, it would be.
but
I
that
see
could
the
be,
clarity that you're talking
that
about.
could be clearer.
Yeah, I was thinking I was thinking of the AFL as a provider also, but they're really, they're employees of the provider agency, so.
Not completely true, but close.
When you have a new service for community living as a force, if it's replacing in-home skill building, it implies this can only be done in the home, but in-home skill building wasn't only in the home.
Okay.
So does that mean this is only in the home?
It's
Also be in the community.
Okay.
Do you know how to make slides shoot? My college kid showed me how to make them shoot, like that one with the 5 dots. I said, well, the two have to come across with one is you and the other's blue. I don't know if it's going to be.
So play with the graphics stuff. And how were the graphics in that first one? Were those helpful?
I like the arrows.
The arrows?
Like the continuum and they break it out. Like, for me, it's like,
Yeah, we'll get to them in just a second. Let's see. Let's go, gentlemen, what do y'all have to say? I can unplug this and everything.
Well, I was looking at your slide stuff, Jesse, and kind of the thing that kind of stuck out to me is, and what I've been getting a lot of phone calls about is the SS assessment, and basically who ensures that it's done properly, and where, to me, I see it as a conflict of interest that you all are actually assessing the need and then managing the funds for the need. And I can see where there's a serious issue there, even though you talk about there's a separation. Y'all still all work with the same organization. So that's something that parents, I talk to parents, they talk about the downsizing of the need. So, or the not trying to look at it in a realistic view. that are doing this.
So we should definitely acknowledge that conflict may exist.
Yeah, and who actually ensures the SS assessment's done right? Because I've heard different things about the committee that does the SS assessment reviews. I heard that there's one person, I've heard there's a group of people, but it'd be nice for people to understand that there are people watching and looking and overseeing that.
Okay.
Because I can see where that could be a misuse of power.
Yeah, when I talk about how we do the inter-rater reliability with AAIVD.
You might do a separate training, a little bit on our process, just a PowerPoint that explains it by itself.
Okay. And I also think you should talk about your appeal rights, because there's a lot of people that don't realize exactly, if we don't agree with this and, it's not there, that they have actually a right to appeal. And that's something you should talk about as well.
Make it clear that due process is available at each step. Okay.
Right, right. And on the page 13, where you're talking about the different things that they have to be trained on, that might be a good place. Is Smokey looking at the College of Direct Support, or is that something still being discussed at by DMA as a way to try to meet those qualifications?
It is something that we are exploring. DMA has lended support to this concept by putting those expectations in the waiver. So we'll have more about that going forward, because some things are happening with regard to that to make it easier for providers to help staff meet these expectations.
And is there any expectations for the care coordinators because some of this stuff I could see where the care coordinators need to have that expectation as well in their training.
I was going to say, they don't even meet the DSP competencies.
Yeah, pretty much.
Okay, we're fine then.
That's all I have.
And QPs. Okay. Those are good suggestions. Thank you. Anything else in Silva? Okay. Let's move to Boom. What are the thoughts of Boom?
Jesse, I've got actually a number of issues with this, as you know, but I'll limit it to 4 tonight when it comes to this. Speaking to the developers of AAIVD, they have reported that the SIS score only accounts for about 40 to 50% of the proposed budget in their statistical analysis. Therefore, we're a little uncomfortable with how much of the statistics is coming from that SIS score. I understand you put in other variables to be factored in, but those variables are somewhat squishy at best.
Okay.
And you want to hold to validity and reliability, and those two things, if those two things aren't accomplished, the whole basis for the score and everything that's based on the score comes into question.
He's 100% right.
Are you counting the thing you're supposed to be counting, and can you do it accurately time after time, 1,000 times out of 1,000 times? Those two things are very difficult to achieve, especially when time, such a large extent, I think well over 40 to 50% of the budget is tied off of the SIS score. That's one issue. The second issue has to do with the competencies and qualifications and certifications and all those kinds of things that you're asking for direct care. I actually like that change. I think that's a good step in our direction. I wish you guys had the same level of care for the SIS assessors and the care coordinators who are actually asking the questions for through the statistics and the consistency of the SIS assessment and the implementation of the SIS assessment. I really don't mind you guys doing it for the direct care. I understand that. I understand that need. And that's been talked about for quite a while. But that need also needs to be the same level of competencies, certifications, and level of knowledge about statistics, statistical analysis, means, medians, modes, normal curves, standard deviations, all those kinds of things need to be there so that you're getting an accurate score. Because if you're not getting accuracy, the rest of it is good in theory, but that has to be really solid. And I don't really feel like it's solid. When the questions can change depending on how you look at each individual question of the SIS score. I like that same level of certification, training that has to do with working with the budget.
Okay.
And why that hasn't been accomplished. Because you've been doing it for a number of years. And it's my thought that they should be very, very, very competent by this point. Instead of unknowledgeable and as untrained as they are. I understand they've had minimal training. They've had directed training directly to the test, but they don't have a general overall knowledge of statistical analysis, basic stats, and an understanding of what these numbers actually represent.
You know,
And also, go ahead.
I was gonna say, I do hear some of the concerns, but, I think one of the failings personally that exists in our system is the amount that we place on the care coordinator. And that's part of why we have some challenges. So, I think we need to look at it in several ways. But I am hearing those concerns. You had a couple more.
Yeah, there hasn't been any informed consent to the parents about how this will be used, when this will be used. There was just no, and it's not in the assessment, there's no informed consent to the parent. Anytime you use any research at all, at any university level at all, there's informed consent, whether it's minimal or a lot. And I don't feel like the parents have been made aware of how it's used, why it's used, that they have the right not to. All of the things that come with informed consent, I don't think have been placed in. That's just part of good research and good practice. And also each of the disciplines are individually leveled, that you cannot practice outside your level of competency. And if your people are not competent and they're practicing on something they're not competent on, then they're practicing outside their level of competency.
Excellent point.
Does that make sense?
Okay. I've just counted 3. Was there one more? Or was that
I got it into the other one, it's fine.
Okay. All right, thank you for those comments, and let's see, anyone else in the room?
Sergeant Jesse. I was under the impression originally that, for residential sports, the limits on sets of services, would include community networking, day sport, sport deployment. At one time, there was discussion of the respite for residential sports also being in that category. Is that not anymore?
No, not based on what I read in the posted document. They moved it out from being part of the services that were available periodically to where you can receive it, but it can't be provided on the same day. In one of our meetings, we talked about how it appeared that what they proposed originally, respite was going to be one of those services that could be part of the 40 hours available.
No, how much, but you're saying no.
No, it's not part of the limits
Okay.
in the hours, but it can't be provided on the same day as residential sports. So you basically got your own limit because if a person receives residential sports on Saturday, they can't receive respite.
So is respite going to be a daily service?
Respite will have a daily rate based on what I understand. They'll also have an hourly rate.
Will it have levels?
Will respite have levels? Probably not to my knowledge. Well, let's see, let me finish in Boone, okay?
Okay.
Was there any other thoughts in Boone?
Yeah, I'm sorry, we've got this written in a 2 or 3 page paper that we have suggestions for improvement for the development of the SIS, and the development of this. I don't know if you've received that or not.
Some of it's been uploaded. It's been uploaded into Alpha with the SIS assessment that was done for one of the children. Well, actually the 16-year-old.
And it's been forwarded.
And it's also been forwarded to management, Allison says.
It's been forwarded to me, Allison.
It went to Rhonda.
Rhonda Cox.
You sent it to Jesse as well?
I'll be glad to send it to you, Jesse.
Okay. You don't really have to. Sometimes ignorance is bliss, right? So, okay, so I'll get that document, and anything else in Boone?
I vote that we have a vote on it. That would be, that's all I can say. That's up to y'all.
Have a vote on this PowerPoint, or?
I think it's already been straightened out.
Yeah, the waiver's pretty much ironed out. The only thing we can really change is this PowerPoint. But that's, I'm hopeful that y'all at least saw some positive things in this document.
Has it been approved by CMS?
The PowerPoint? No, the waiver's been submitted. It was submitted September 18th. So 10, 11. The earliest it can be approved would be January 1. The 90-day clock is up 12/18. So if CMS doesn't reply at all by 12/18, it's implied that we would implement this waiver. But they will likely reply with some type of feedback. And then that stops the clock until we respond. And it's really unlikely that this will actually start January 1. I think that it is on track though to start no later than March 1.
We're not having to change our budgets and plans. It takes away some of that clock.
Yeah, and you see the thing too is you've got the fact that they changed it to where you do have that rollout instead of this sudden hard change makes it a lot easier to implement. Because they give us a 2-year rollout period, so
We'll be
we have
writing a new
time
waiver
for
in 2 years.
moving into it. It's kind of funny, it's a 2-year rollout. Then the waiver, it's time for a new waiver.
Waiver in a year.
Just the one in the room with the diagnosis.
So let's see, we need to go to Lenore for thoughts.
Yes. Hello, I do have a thought or two. This is Mary Short. Hi, Jesse. Hi, everybody.
Hey, Mary.
So these slides don't talk about the CIS verification committee. These slides don't talk about what is used by the CIS verification committee. It would be real important for families and providers to understand that the CIS verification committee is looking at those supplemental questions, and they will look at, I recognize that ringtone, they will
I'm sorry, Mary.
say hi for me. It's been my horrifying experience to learn that the CIS verification committee will take a current CIS, say it was done last month in August, and they will then look at the ISP that is on file, rather than looking at an ISP that was written after the CIS assessment that includes all of the discovery that took place during the CIS assessment. Because that's the point of the CIS, isn't it? That those sections of the CIS are included in our ISP documents. So there's a real disconnect to what the CIS verification committee is doing and what care coordination is doing, and there is certainly a disconnect as to what the guardian or the families or the individual understands is happening with their CIS assessment. I also wonder, I don't see any explanation about the resource allocation model and what, I mean, I see that they're using, so 3 parts, right? That it's the CIS, the living arrangement, and the age. So what are the weighted factors in the resource allocation model to age of the individual? And then on the limits on sets of services, I'm a little surprised that age isn't a factor in the limit on sets of services if the 84-hour limit applies to adults living in the family home, but the 84-hour limit applies to children not during school sessions. So how is age not applied to the limit on sets of services, but is applied to our resource allocation? Could that be better explained?
Yes, it could be. I understand what you're saying there.
And then also the slide on page 12 about community living and supports, where it talks about exceptional needs, and it says up to 16 hours per day for a 6-month time frame, or more than 16 hours a day may be approved for up to 90-day periods. So is one of those multiple? Or is it only a one-time exception, or is there some determination about what is a permanent exceptional need and that you need to be moved out of a community living and supports and into a residential support service? That needs to be clarified, because it's my understanding that's the truth. If you have a permanent exceptional need, you must be moved out of community living and moved into residential supports.
Thanks for those comments, very useful. Anything else?
Nope. Anybody else in the room? Thanks.
Sure. Okay, anything else in Asheville?
Josie, I just wanted to say something. It's a shame that they didn't carve out a few hours of respite for the AFL providers.
It's really crappy.
Folks work all weekend and they just want a couple of hours to go out to eat. And they're not gonna be able to
Yep.
build the residential supports, even though they're working and running the goals. I just don't see that happening a lot. So what our families are gonna have to do is they're gonna have to take the whole day to do some respite.
Yeah, a couple hours would be.
A couple of hours, really. If they could have some kind of limits on that, would be nice.
It's horrible.
Is there a limit on the number of hours of respite in a plan?
I didn't see one in my first glance through, but I'm hesitant to answer.
And if there's not one and you can't do it on the same day, won't that just increase the cost if you're not gonna get the residential, but you're gonna build
Well,
20 hours of respite?
I do know that the one limit that's in the respite definition is that
They just hate it, Katie.
the cost of respite for a day cannot exceed the cost of institutional care for a day, which means that basically respite would be limited to around $230 a day.
Makes sense.
Jesse, this is, like Jerry had his in that big rollout, the 5,000. And that's been 3 years ago now coming up. Will Jerry now be coming up for a reassist before his plan in March?
Yes, it's very possible that he would.
Hear that, Alan?
He may not, but it's possible.
Okay. I just want to make sure.
Because the census is supposed to be done every 3 years
Okay.
for adults, 2 years for children. And the numbers, I'm tired, I can't remember. The cutoff age is, I believe, is 22. Well, for the census it is, but for different pieces, there's some different numbers in the waiver that I didn't put in the PowerPoint that confused me. So that's why I didn't.
When you're combining the personal care, in-home skilled building and in-home intensive, the in-home intensive requires nursing. Is that coming out of the plan?
That's not true.
The in-home intensive doesn't actually require nursing.
Thank you.
It depends on the individual. Yeah, it depends on what's identified as needs for the individual. Because sometimes the person has medical needs, sometimes the person has behavioral needs. Now, the old enhanced personal care definition required nursing. That's probably just one of those relics, because we're always dealing with relics. Like I had the question come up about respite being provided every Friday. Respite can be provided every Friday, but in the waiver, 2 waivers ago, it couldn't be.
It's like, oh yeah, that's neat.
So you're almost at a disadvantage when you've been in it a while.
What's the combined rate for community living and support? Has that been?
Smokey has not set a rate for that service. The rate that DMA used for the calculation was $471 a unit.
And does that mean then that the enhanced rate for the individual rate is gone for those with exceptional needs?
No, it does not mean that. The MCO remains the rate setting authority.
Just will there be any increases in residential rates or any of the other?
I can't answer that question. The numbers that were used by DMA and the calculations are comparable. If you go into the very back of the waiver document that's posted, the last appendixes, you can see the rates that are proposed for each year of the waiver. We will be going into year 4 of the waiver. So those were the numbers that they used. The rates for day supports are indicated on that page, but that's an average of individual and group that's indicated for day supports. And I can't remember the number. But we haven't set any rates we will have to set a rate for us. We'll have to establish codes and rates for supported living and community living and supports. And that will have to go through certain processes at Smoky. The numbers that were provided by DMA will be some of the guideline. They also provided proposed rates for supported living. But just because we don't know that those rates will work for us, we'll have to take a look at them.
This intensive, then what replaces the intensive in-home, the intensive community living, continues, I believe, to require a family plan or technology. So these people who need more than 12 hours a day, you know, Dave Richards said basically, you know, you don't have much choice at staying home. Is anything going to change with people who need more than 12 hours a day but are under 135,000?
I know that the 84-hour limit will continue unless you're exceeding it up to 6. You can get up to 16 hours a day for 6 months, and then after that it's the 90. I don't know. I think that the intent if a person needs more than 12 hours a day, the thinking is that it would need to be shifted to a 24-hour type placement.
I had asked Peggy at Monarch, can a 3-bedroom group home afford to provide the one-on-one care that the high-end, over 12-hour-a-day, Your Little Princess, requires? And her answer was no. And I have to believe, because Peggy's a pretty savvy business person, that if anybody could make a 3-bedroom home work, it would be her. But those people who need the one-on-one, what's going to happen to them, Jesse? Are we going to have generous respite?
That's probably one of the options.
But even with generous respite, if you're gonna go down to a rate that doesn't meet their need, it doesn't mean anything.
I have one more question. I feel very, very short light this afternoon, Mary. The supporting living service. I have worked with people who have 3 adult children. If mom leaves the home and there are 3 of them, can that work as an unlicensed group home? Well, all right, let me rephrase it. Can you get 24-hour care in a supervised living situation? With 3 consumers.
If the consumer's on, yes, you could.
But then what would happen? Because you can't get supported living, the supported living if your parent lives there.
Yeah, you couldn't use supported living if the parent lives there.
So if Peggy and Monarch can't make a 3-bedroom, one-on-one requiring staff work, but mom can move out and supported living might be able to work.
I don't know that supported living would provide one-on-one.
Says it offers 24-hour coverage.
Yes, 24-hour coverage and 20 and one-on-one is very different things.
She's doing a pretty good job doing it.
Because
Person with one staff.
Yeah, but they're not one.
Yeah. There's only one.
But each one requires
that's one of those that I'm going to solve. Let's see. Or do you have any others? Let's see. One quick go around. Anything else in Silva?
I do have one more.
I don't believe so.
Okay. Anything else in Lenore?
Yes, I have one more question. You said something about maybe Smoky was going to reevaluate its relative as direct service employee policy. And these new competencies are coming up, so that obviously means we're not going to have direct support professionals unrelated. As part of that review, are you going to allow a more generous review for relatives to be backup staff rather than these services being unbilled to the tune of $450,000 a year worth of unbilled services on backup staffing not being available? Or is that going to be part of your review?
allocation to smoking. We will not even be reviewing that. And most backup staffing circumstances are addressed by that up to 40-hour limit.
But you act as if there's actual staff. There just isn't. I mean, you know for a fact, Jesse, I'm approved to do all 84 hours of Katie's services. And we just had a horrible incident involving trying to request in-home intensive supports and there not being a network provider. And we've run into the same issue with trying to find a respite provider. There's no network provider for respite. So needs are being unmet and relatives can't provide services. We can't be backup staff. I mean, it's just, I guess there is no choice but institutions. At least I know at Riddle or Murdoch or Caswell or at least I know there's always backup staff at those places.
That's accurate, yes.
You just can't keep forcing labor on family members.
Okay. Thanks for your comments, Mary.
Okie doke.
We're all good.
Okay. Well, we will be back in October. Oh, I needed to share one other thing. We will be doing family forums. Our first one's in Caldwell County, October 12th. Caldwell County Library. We're doing one in the Boone training room on October 14th. Asheville here at Ridgefield on October 21st.
What time, Jesse?
All of these will be from 6 to 8.
6 to 8 here.
And we'll be sending out a flyer by the end of the week with the dates. And then there's one for October 27th at Rutherford Health Center.
October 27th. Where at?
Rutherford Health Center.
Oh, okay. Rutherford 6 to 8.
Macon County County Public Library, November 9th. And Haywood County DSS, November 16th.
Let's go to Macon County for the fun of it.
So we'll be taking your feedback on this PowerPoint, adding things to it, and replacing with a source document for the family and provider forums. We'll be communicating the forums in our provider communication bulletin, the news you can use, and we'll be giving flyers to care coordinators to share with families starting October 1.
Since we had so many problems, should we approve the minutes from the last meeting?
Use your other hand.
Sure.
Here.
You can move
I make a motion to approve the minutes from the last meeting.
And I second.
we will call them to.
Jesse, if you give me some
Thanks, y'all.
flyers for these by the